I would now like to request Professor Sumaira Altaf to come for her presentation. Thank you, so nice for long waiting.
Altaf from Al-Shifa Trust Eye Hospital in Rawalpindi. Professor Ziaul Islam Sahab, Professor Zia Mohammad Sahab, Professor Naeem, Sanaullah Jan Sahab, Sadia Sethi, Professor Sadia Sethi, Professor Nazli, and all the speakers who have made my job easy today by presenting such beautiful and comprehensive talks and a very wonderful discussion, I would say, which is much needed on such forums so that we can all be on one page and we can develop a consensus to give quality management and treatment to our children. Many of the things that I have with me in my presentation are the same that have been already talked about. But there are a few highlights, there are a few things that I would like to highlight. And it is because I've been practicing pediatric ophthalmology at Al-Shifa since 2007. And when I was asked to come here and talk about pediatric cataracts, I consented because it is one of the topics that I am very much, I very much want to convey things to people about it, convey my experience and knowledge, whatever I've gained over the years. Because this is, and why is that? Because it is one of the most common, like it has been said, it is one of the most common problems that we are facing in our culture especially. The number of cataracts that we are dealing with, the pediatric cataracts that we are dealing with are staggering as compared to those that are seen in the West. Global information, agar aap dekhein regarding preventable blindness because of pediatric cataracts, these are all numbers that are available, but like Dr. Irfan said, they don't tell us the exact impact that they are having on the lives of our next generations. Like the presenter said earlier, 1 to 15 per 10,000 birth rate जो है इसका prevalence है. लेकिन जो हमारे पास numbers हैं in our country, it's not unfortunately like many other statistics, we don't have the numbers available to us कि पाकिस्तान में हमारे पास इसकी क्या prevalence है. We generally जो हम अपनी prevalence और incidence rates हैं वो उनको हम match करते हैं with India because इंडिया की अंदर स्टडीज़ हो रही हैं, ज़्यादा हमसे बेहतर रिसर्च के अंदर वो लोग इन्वॉल्व हैं. एट द सेम टाइम उनकी जो सोशियो इकोनॉमिक और पॉपुलेशन के फिगर्स हैं वो तकरीबन हमारे यहाँ तकरीबन ऐसा ही सब कुछ है. So in India, they say that 10% of childhood blindness is because of childhood cataracts or pediatric cataracts. And this again is sometimes I feel that the number seems a bit underreported. All of us are doing our bits to manage this kind of workload, this kind of challenge, because it is a huge drain on our the financials and the services that we have to provide to deal with such numbers. I'm working at Al-Shifa Eye Trust Hospital in Rawalpindi, and we are contributing and doing our bit. We are currently operating or treating about 2,000 pediatric cataracts annually. And it is perhaps one of the highest numbers that is being operated upon in a single institute. And the reason why is because we get a large number of referrals from all over the country and even from Afghanistan and Iran. So sometimes the number is so overwhelming that we are, as pediatric ophthalmologists, find ourselves overstretched and overburdened to a limit. Now coming to the dilemma of diagnosing a pediatric cataract. You must remember when the patient is coming to you with a white pupil or leukocoria, which happens to be the most common sign or symptom that the patient presents with. So always remember that every white pupil is not a cataract. Even in today, many of my patients that are being referred from the periphery, parents आएंगे और कहेंगे जी ये सफ़ेद मोतिये का ऑपरेशन कराना. And when I see the child, it is either a grade 5 ROP or a retinoblastoma behind it, or a torch or a PHPV patient. So, and I would feel कि ये जो ophthalmologist था, इसने why did he not see the child? Why did he not? How could he say that this is cataract? Sometimes, the diagnosis, to me, it's very obvious. But I feel when you don't have the right equipment, because in the periphery you may not have the B scanner, and you may not have the right equipment to look at the anterior segment of the child. Because if you don't have the right equipment, you only have a torch or a thelmoscope, आप बच्चे को टेबल माउंटेड स्लिट लैम्प पे नहीं बिठा सकते, आप उसकी डेप्थ नहीं दे सकते, ऐसी शैलो डायग्नोज नहीं कर सकते, and a very small people which is not dilating, and there is the only thing that you can diagnose is a leukocoria. So, in having said that, I would suggest that if you cannot diagnose, if you don't have the equipment or the you have some kind of suspicion that it might be something else other than, because अगर आपके पास microcornea है और अगर आपने history लिया और there is history of prematurity, microphthalmia है, or there is other associated systemic issues along with the cataract or the white pupil, then, or there is family history or history of tumors or blindness or retinal detachments in the family or siblings, then kindly refer but not tell the parents that it is a cataract. Then once the parents are convinced that this is a cataract, they want us to remove the cataract and restore the vision. So it becomes, so the diagnosis is again a challenge and a dilemma. In adults, diagnosing cataract is fairly simple, but in pediatric cases, even the diagnosis of cataract becomes a problem. So when dealing with a white pupil, the differentials can be quite scary. So make sure that you're not dealing with persistent fetal vasculature. Like Dr. Nazli pointed out, it can look very much like a simple cataract to begin with, but if you do a dilated pupillary exam and you see the fundus, you can easily diagnose it. The most feared association or the differential diagnosis for pediatric cataract is retinoblastoma. Retinoblastoma can masquerade as ocular inflammation. Patient आपके पास end of की picture के साथ anterior segment inflammation के साथ present कर सकता है, glaucoma के साथ present कर सकता है, and even secondary cataract के साथ present कर सकता है. So it's imperative that you look for a pathology in the posterior segment. No child should be operated upon unless and until you are sure that the posterior segment is fine. Don't operate on that child. Get a B scan done. That's all that is needed. Next differential would be the retinopathy of prematurity. Unfortunately, we are not doing enough for it, but I'm happy to see that there are centers sprouting up all over the country where more and more screening for our ROP is being done, and more ophthalmologists are now becoming aware of the need and the clinically more aware that this can be retinopathy of prematurity. But still a lot of effort and effort is needed so that we can save our children from future blindness. Chorioretinal colobomas can sometimes present as leukocoria. You know, the reflex from the retina, the coloboma can give a white reflex. Again, the Coats disease is a unilateral phenomena in boys usually, and sometimes it also depends. It also comes ल्यूकोकोरिया के साथ प्रेजेंट करेगा, या आपको रेड ग्लो सही नहीं मिल रहा, रिफ्लेक्स अच्छा नहीं आया, किसी ने कह दिया कैटरेक्ट है, बट दिस इज़ वन ऑफ द डिफरेंसेस जिसको हमें देख लेना चाहिए एंड अकॉर्डिंगली ट्रीट करना चाहिए. So once you have, these were only a few of the differentials जो उनकी बहुत ज़्यादा significance है, जो कि treatable causes हैं, जिनको अगर आप treat नहीं करते या आप उनको timely diagnose नहीं करते, तो you can end up in big trouble. Once you have established that this is a cataract, and you, how do you establish that? So what are the common signs and symptoms जिसके साथ cataract present करेगा? वो obviously एक red reflex है जो clinic, either the clinician has picked it up or parents भी बाज़ दफ़ा आते हैं कि जी हमने photograph में देखा तो इसका एक red reflex जो कैमरे के अंदर उसकी आँख के अंदर अजीब सी shine थी. So that leukocoria can also, ये rarely होता है, but that can also how it can present. Sometimes the children present with strabismus, especially unilateral cataracts or asymmetrical cataracts, जिनमें एक side पे ज़्यादा cataract मौजूद है, and one is a better eye than the other, and the weaker eye goes misaligned हो जाती है. Again, अगर the first 3 months of life में cataract, dense cataracts को हम bilateral cataracts को address नहीं करते और visual access को clear नहीं करते, the child might develop nystagmus, and that is how the child will present to you. Parents आएंगे और कहेंगे जी इसकी आँख हरकत कर रही है. Parents might come to you and say, complain about the visual inattention, because इससे पहले तो ये ठीक था, लेकिन अब ये आके ना ये मेरी तरफ नहीं देखता बच्चा, और ये इस तरफ मेरे चेहरे को नहीं देखता, और हम बुलाते हैं तो ये नहीं देखता. The thing is, what you need to understand in that history is that the parents have probably not noticed the visual inattention before 2 or 3 months of age, and that is because the child is too young, and eye movements और fixation patterns को parents बहुत ज़्यादा पिकअप नहीं कर सक रहे होते, वो उस वक्त उसको बाज़ दफ़ा they don't really see what's happening. It's difficult to do that actually. History should include the following. It should include the pre and postnatal history and the review of systems for the baby, and family history is also very important, like we said earlier. Okay, so you have diagnosed now, you have ruled out all the secondary causes, and you have established that this is a pediatric cataract, right? So now you need to examine the child, and so that you can form a plan of management in that child. सबसे पहले आपने उसकी visual assessment करनी है, उसका visual behavior pattern देखना है, सही? तो उसके लिए जो already हम बात कर चुके हैं, लिए ratings हैं हमारे पास, preferential looking tests हैं, smaller children, OK and drums. What it does is again that the human mind is trained to look at a pattern than at a plain surface. तो आप if you have a plain wall है जिसके ऊपर कुछ चीज़ hang की हुई है, so automatically आपकी जो eye fixate करेगी वो जाके उस feature पे, उस picture पे, because you are trained to do that. Your mind prefers to do that, and that is why it is called a preferential looking test. So in these tests, what is being done here is that against a plain background on one side, more and more finer gratings are being presented to the child, just to see कि वो किस हद तक की contrast को appreciate करेगा. If जी, तो these are the Lia grating symbols. ये Lia gratings जो हैं हमारे पास, ये हैं, यहाँ देखें फाइनर लाइन से लेके ये this is the plain board जो है हमारे पास, and this is the अगर आपके पास जो बच्चा ये appreciate कर रहा है, इसकी limitation ये है कि देखिए आपके you have to sit very close to the child. Again with Cardiff cards, this is again another type of preferential looking test, and the reason वाई, बिकॉज आपने इंगेज करना है बच्चे को. अगर आप बच्चे से बहुत दूर चले जाते हैं, बच्चा विल लूज इंटरेस्ट एंड द बेबी विल नॉट लुक एट व्हाट यू आर ट्राइंग टू शो द चाइल्ड. सो ये टेस्ट जो डेवलप किए गए हैं, ये बच्चों के इंटरेस्ट को सामने रखते हुए उनको इंगेज रखने के लिए आप उनके करीब बैठ के टेस्ट करते हैं. लेकिन इसका ड्रॉबैक ये होता है कि ये ओवर एस्टिमेट करते हैं बच्चे की विजन को. कार्डिफ कार्ड से जो हम मैक्सिमम विजन असेस कर सकते हैं वो 6/12 है. और इसी तरह जो ये लिया ग्रेटिंग्स हैं, लिया ग्रेटिंग्स में हम जो इसका यूनिट है दैट इज़ लाइक द मैक्सिमम है वो 8 CPCM है, विच इज़ दिस कार्ड जो सबसे फाइनल लाइन्स है. 8 CPCM means 8 cycles per centimeter, because in 1 centimeter there are, sorry, in 1 centimeter there are 8 lines, 8 cycles of white and black gratings, right? So 8 lines 1 सेंटीमीटर में मौजूद हैं. अगर ये वाला कार्ड वो बच्चा अप्रिशिएट कर रहा है, every time you do this and the child looks at the gratings and not at the plane, और आपने हर दफ़ा देखना है कि वो किस तरफ उसकी आंखें जाती हैं. This is a subjective test, remember that. So like Professor Zia Mohammed said कि आपको बच्चे को बार बार देखना पड़ता है बाज़ दफ़ा to assess कि उसकी विजन कैसी है and whether there is a preference in one eye or not. Monocular vision in this age group is very difficult. So monocular vision assessment के लिए you have to distract the baby, you have to put time and effort into it, you apply a patch, and then when the child has stopped crying, then you can do these tests again. Same test can be done monocularly after you patch the eye. You apply the patch to one eye, then you do the test and you apply the patch to the other eye and do it. Because otherwise अगर आप हाथ रख के, कार्ड रख के या कोई भी ऑक्लूडर रख के करने की कोशिश करेंगे, the child will not cooperate. Again, IOP measurements in children are mandatory. At least once आप उसकी, जब वो आपकी OPD में आता है, प्राइमरी विजिट है, उसका पहला विजिट है, you must try and make an effort to get an IOP reading for that child. Also, corneal size, pupillary status क्या है, pupil dilation कितनी बेहतर होती है, उसकी persistent pupillary membrane तो नहीं मौजूद, कोई और eccentricities हैं, dystrophy है. Because this is important. Why? Because this will help you to plan the surgery. If you feel कि ये pupil dilate नहीं हो रहा in the OPD conventional तरीक़ों से, तो you have to write it on the card so that when the surgery is planned, तो आपको पता है, आपको मालूम है, आप उससे पहले ही arrange करके रखेंगे, आप आयरोसुक्स वगैरह arrange कर लें so that your surgery can go as planned. Anterior chamber depth is very important. PHPV में also in end stage advanced ROP में there is iris lens diaphragm जो होता है वो आगे की तरफ पुश हो जाता है, and इसकी वजह से यहाँ पे shallowing of the anterior chamber होता है, and that's very significant. अगर if there is cataract along with this shallowing of the anterior chamber, then you should be very careful. You go for the B scan immediately. Morphology of cataract again is very important, like already discussed earlier. इसमें मैं posterior lenticonus के हवाले से बात हो रही थी, तो उसमें I would जितने papers articles we have seen, उसमें ये बहुत ज़्यादा बताया जा रहा है कि जी lenticonus जो है वो आमतौर पे monocular uniocular होता है, but unilateral हमारे यहाँ maximum जो मैंने operate किए हैं वो अगर if not more than, but it is almost the same number as unilateral lenticonus. And lenticonus is very interesting कि ये एक large defect है in the posterior capsule, और बाज़ दफ़ा एक दो दफ़ा तो यहाँ तक था कि इसमें लेंस मेटर पीछे की तरफ क्या होता है. You can actually see the fishtail moving the eye preoperatively, and you can diagnose it in your OPD as well if it is not a white cataract. If it is a full total cataract with a lenticonus hiding behind it, then क्लिनिकली आपके लिए जज करना मुश्किल है, बट देन अगेन बी स्कैन कैन हेल्प यू। बी स्कैन्स में जो पोस्टीरियर कैटरैक्ट्स होते हैं, जो एंटीरियर विट्रस को इन्वॉल्व कर रहे होते हैं, वो आपको देखने से अंदाज़ा हो जाता है कि दिस इज़ प्रॉबेबली अ पोस्टीरियर लेंटिकोलस।
Sorry, Sumaira, is it associated with Alport syndrome? वो interior है?
वो इंटीरियर होता है जी, इंटीरियर लेंटिकोलस। देखिए, ये जो हैंड हेल्ड स्लिट लैम्प्स हैं, ये आपके लिए बहुत इंपॉर्टेंट हैं प्रोन बच्चों में की एंटीरियर चैम्बर की एग्जामिनेशन के लिए। तो जहाँ जहाँ फुल फ्लेश्ड पीडियाट्रिक ऑप्थल्मोलॉजी प्रैक्टिस की जा रही हो और उनके पास ना हो, तो दे शुड गेट दिस हैंड हेल्ड स्लिट लैम्प फॉर बेटर वैल्यूएशन ऑफ द एंटीरियर सेगमेंट ऑफ द चाइल्ड। ऑल्सो हमारे यहाँ ट्रॉमा बहुत ज़्यादा कॉमन, इट्स सो कॉमन एंड सो अननेसेसरीली रैम्पेंट कि हमें बाज़ दफ़ा आई एम स्पीचलेस कि हम क्यों नहीं बच्चों को बेहतर इन्वायरमेंट प्रोवाइड कर सकते इन आर बेटर होम्स। देखिए, चिल्ड्रन हैव अ हैबिट ऑफ गोइंग आउट एंड प्लेइंग अराउंड एंड डूइंग स्टफ, लेकिन हम even in our homes, at homes we keep our sharp objects, sharp things lying around where the children can reach them. Knives के साथ trauma है, pencils के साथ trauma है, scissors के साथ है, झाड़ू के साथ है। और environment की जिस तरह बात की I think डॉक्टर राहिल ने, कि environment किस तरह बच्चों को affect करता है। बच्चे अगर child psychology के ऊपर देखें तो children are like sponges and they can just absorb everything from their environment. And जो आपने कहा कि जी ईद उल अज़हा पे वो इस तरह का ट्रॉमा और बाकी गन शॉट्स वो पैलेट गन के साथ, इसी तरह भी जब अर्तुरुल का सीज़न चल रहा था तो सर आपको आई थॉट कि आई शुड रिकॉर्ड दोस केसेस जो कि मेरे पास एंड ऑफ के आए, बिकॉज वो अर्तुरुल बना के उन्होंने वो झाड़ू के तीलों के साथ तीर अंदाजी करते थे और वो सब बच्चों की आंखों में एवरी अदर डे अ चाइल्ड वुड कम जो इस ट्रॉमा के साथ, इस किस्म के ट्रॉमा के साथ, और वो अर्तुरुल बना हुआ था या उसका कोई दोस्त बना हुआ था। सो दिस इज़ व्हाट इट इज़। और हमें बच्चों को वायलेंस और कॉन्टैक्ट स्पोर्ट्स में केयरफुल होना और शार्प ऑब्जेक्ट से दूर रहना, स्पेशली जब स्कूल में हो। तो आई थिंक हमारे एज डॉक्टर्स पेरेंट्स को हमें काउंसिल करने की ज़रूरत है, बट इट्स समथिंग दैट इज़ परहैप्स बियॉन्ड द स्कोप फॉर व्हाट वी कैन डू। लुक फॉर साइंस ऑफ पुअर पोस्ट ऑपरेटिव विजुअल प्रोग्नोसिस। देखिए, अ चाइल्ड हु हैज़ ऑलरेडी डेवलप्ड निस्टैग्मस, उसमें डेंस एम्प्लायोपिया आप एक्सपेक्ट कर सकते हैं। सो आपने विजुअल प्रोग्नोसिस उसको उसके पेरेंट्स को समझा देनी है और उसको आपने डिस्करेज बिल्कुल नहीं करना, बिकॉज इफ वंस यू डू दैट the parents might not be willing to make the extra effort and go for amblyopia therapy and the rest of the treatment is required. Other things that can tell you that the prognosis, the visual prognosis might not be that good is if there is ocular digital sign. आई पोकिंग मौजूद है, प्रॉबेबली वहाँ पे रेटिनल डिस्ट्रोफीज़ हैं। हमारे पास जो बहुत कॉमनली देखने में आती है दैट इज़ लेबर्स कंजेनिटल एमेरोसिस एंड दैट इज़ वेरी फ्रीक्वेंट एंड यूजुअली द चाइल्ड प्रेजेंट्स विद आई पोकिंग, और आई पोकिंग की वजह से बाज़ दफ़ा उसमें कैराटोकोनस डेवलप हो चुका होता है या उसमें डेंस कैटरैक्ट्स होते हैं। Cataracts associated with other syndromes, with systemic associations, cataracts secondary to torch and associated with retinal dystrophies, CNS abnormalities. All of these, they can spell bad news for the prognosis, the visual prognosis for the child. Okay, once you have examined the child, you are now planning to treat the patient, and then you have to decide कि क्या आपने इसको treat करना है, आपने क्या करना है, आपने how to manage. So the first question comes to whether to go for cataract surgery, whether to operate or not, and if yes, when to operate, and if not, then how to manage. If surgery is planned, should the IOL be implanted? And if the IOL has to be implanted, what IOL power should you select? And if the IOL implantation is not planned, then how to manage and follow the patient. So at every given turn, you have to make a decision for that child, and you are responsible, you will be responsible to for that decision, and which will affect that child for the rest of his or her life. So that's a big responsibility that the pediatric ophthalmologists carry. Not all cataracts need early surgery. We have already talked about that. So what is the non-surgical management? देखिए हमने डिसाइड किया कि जो विजुअली सिग्निफिकेंट कैटरेक्ट्स होते हैं वो हैं जिनका डायामीटर 3 मिलीमीटर से ज़्यादा है, सेंट्रल हैं, पोस्टीरियर हैं और 3 millimeter से ज़्यादा हैं. They are known as visually significant cataracts because they are potentially amblyogenic, and they are significant enough. The opacity is significant enough to decrease the vision in that eye, and that is an indication for treatment. But if it is other than that, then you can observe the eye, and you can, while you're observing, आपने उसमें refractive error को देख लेना है, आपने देखना है PHPV वाली आँख होगी, तो वो स्टीपर कॉर्नियाज होते हैं, एस्टिग्मेटिज्म उसमें ज़्यादा होता है. प्रीमेच्योर बच्चे अगर उसकी हिस्ट्री प्रीमेच्योरिटी की है, अगेन रिफ्रैक्टिव एरर्स ज़्यादा हैं, अगर उसमें कैटरेक्ट भी साथ है. सो आपने यू हैव टू एड्रेस द नेवर let the child go home without doing a cycloplegic refraction. And if you decide not to operate and go for non-surgical treatment, and there is a partial cataract, and you can then dilate that pupil a little bit with phenylephrine 2.5% along with patching of the good eye. And this will help support the vision in the weaker eye till such time that you can go for surgery. Either the cataract progresses, or else while you are, because even if it is a partial cataract and even if it is asymmetrical, it is again amblyogenic to some extent. So non-surgical treatment is not कि आप observe कर रहे हैं और कुछ नहीं कर रहे, but इसमें आपने dilation और refraction और साथ में patching या occlusion therapy को बहुत ज़रूरी है इसको, and with regular follow-ups of course. Sorry? Yes, but 2.5%. It is the diluted form. जो आमतौर पे यहाँ पे 10% मिल रही है, which is not safe for younger children. लेकिन in a diluted form in like 2.5%, जो हम premature जो babies के dilation के लिए भी use करते हैं, it is that safe. उसकी बहुत बड़ी वजह ये होती है कि आपकी जो dilator pupillary muscles हैं छोटे बच्चों में, वो develop नहीं होते हैं, and they don't respond to tropicamide that easily. So आपको बाज़ दफ़ा cyclopentolate and phenylephrine combination में with tropicamide दो dilating agents आपको देने पड़ते हैं. Okay, so indication of surgery again, like he said कि अगर visually significant cataract है तो उसमें होगी. Cataracts associated with strabismus, or if there is history of photoaversion, cataracts obstructing the examiner's view of the fundus. It's very simple. आपको उसकी vision नहीं है, assess हो रही, आप नहीं समझ पा रहे कि मैंने cataract surgery करनी है. Just आप अपना lens उठाएं, see the fundus. If you have a blurred view of the fundus, आप उसकी vessels को clearly नहीं देख पा रहे और retinal vessels को, then that's the decision for you. Go for surgery. Okay? So that's what I tell the parents कि मैं इसकी आँख के अंदर नहीं देख सक रही, इसका मतलब है बच्चा आँख से बाहर नहीं देख रहा. So that's simple. Go for surgery. So again, timing of surgery, आपने देख लिया, आपने decide कर लिया, हाँ जी surgery करनी है, अब अगले साल आके करवा लेना. Unfortunately, that's what we are doing these days in Al-Shifa, because हमारे पास COVID का backlog इतना बढ़ चुका है कि हमारे पास 1700 appointments हैं जिनको हमने cater करना है, and we are 6 ophthalmologists, pediatric ophthalmologists. It's a big task. So I would really appreciate some help from all of you. But timing of surgery is again very important. Like Professor Jam Mohammed said, कि हम जो unilateral cataracts हैं उनको 4 से 6 हफ्ते के अंदर, और bilateral cataracts को हम 10 weeks में operate. That is the limit. राइट विदिन 3 months अगर आप दोनों को ऑपरेट कर दें विद गुड एम्ब्लायोपिया थेरेपी मैनेजमेंट बिफोर द एज ऑफ 2 years the child is able to achieve a very good visual outcome unless and until there is other systemic issues. So in case of asymmetry, the